Okay, so today we're going to be talking about SMBP devices and kind of getting into an overview of clinically validated devices and how to use them, return on investment for devices. We'll practice a device accuracy test, and then we'll do some looking at appropriate cleaning and disinfection processes for blood pressure devices. So to get us started, we'll just do some of those polling questions. I think Jerry will be pulling those up for us. Just a couple, just to make sure that what we talked about last week hit the nail on the head from what we were supposed to teach you.
So yeah, our two polling questions are, do you refer patients to measure outside of the clinic setting, and do you already have an SMB program?
I think, Jerry, this is from the first week.
What?
I
just realized that
no
I was kind of like, I think I oops.
So if we do, I think I can launch it really quickly. There's a little button at the top.
I thought those questions seemed awful familiar. Thank you. I did. Okay, so we were talking about motivational interviewing last week. So motivational interviewing strategies include all of the following except, and you've got 4 choices there. And then the second question is true or false. Probing questions tend to be very general. So the use of open-ended questions allows you to collect additional information for clarity and or additional information. So I think we just had, we're just on the polling questions. It looks like Wendy just joined us. So Wendy, hopefully you can see those polling questions if you just want to if you have a second to answer those. And it looks like, so for the second question, that's correct. It is true. Probing questions do tend to be very general. So use open-ended questions. And motivational interviewing strategies include all the following except directly confronting issues with that person. So everybody, that helps us know that what we said was stuff that made sense and that you were able to retain it. So thank you, everyone. And I will turn it back to you, Elena.
Thank you, Jerry. So with that, we are going to hop into that round robin. I don't know if either of you want to share any open-ended or probing questions or phrases that you used this past week, or if you want to share any common patient barriers you anticipate hearing from patients regarding SMBP. If either of you want to share anything like that.
I wrote down my 2 open-ended questions. Tell me about how checking your blood pressure fits into your day, and what are some things that get in the way of checking your blood pressure?
Great.
I don't have any, in my current role, I don't have a lot of direct patient access, so I haven't heard any new barriers.
Yeah, absolutely. I know I've heard couple of things, like some patients are still a little bit apprehensive to come into the office, and we're all trying to kind of speed up care along a little bit right now and not spend extra time on extra projects just to get patients in and out so we can practice care safely. So some of those things could be some barriers right now about SMBP, and adding things, whether it's a barrier from the care team's perspective or the patient's perspective. So with that, I am going to hop into our topics today. So the first thing we want to talk about is clinically validated devices. So there are a few different lists here that I have up on the screen. We want to encourage our patients to use clinically validated devices so that we can utilize, well, first of all, clinically validated devices are the best practice, and to be on the clinically validated list, blood pressure monitors must provide peer-reviewed publications showing that they've been tested using internationally accepted protocols for the validation of clinical accuracy. So that's the ultimate reason we want them to use these devices. Outside of that, though, with those CPT codes for billing, there is mention in both of them about utilizing a clinically validated device. So those CPT codes that I mentioned, they came out in January of 2020. At that point in time, the US did not have a clinically validated device list. That didn't come into play until around April of 2020. So at that point in time, when those came out in January, the only 2 lists that existed were this Canadian list and this UK list that are listed here on the screen, which I will click on, but I'm also going to put the link to these slides in the chat in a second. I have that open. So I'm going to show you what the US list looks like really quickly. Let me make sure I can give you this as well. Here's the link to the slides in case you want to click on any of those links. But let's look at the US list really quickly. So the negative part of the US list is that it's pretty short. There are a couple different manufacturers on it, but we anticipate that it will continue to grow over time. Right now it has a lot of Omron devices on it. It has the A&D medical devices, and then some of these are not home blood pressure monitors. So you want to definitely check the key up here at the top. You can select home and just look at those ones. So we have Omron, we have A&D medical, and then we have these Hillrom Welch Allyn devices. So it's a pretty slim list. Like I mentioned, that's not great for clinics, right? If we want to get that reimbursement back, we want this list to be more encompassing. So I'm really hopeful that this list continues to grow. I do know that at one point in time, and I can follow up with my contact a little bit more on this just to confirm, the Canadian list and the UK list, because they were on, because we didn't even have a list in the US, but the UK and Canada did, they were allowing the use of these devices as well. So I'll confirm that. I have a contact that helped create the CPT codes, and I'll double check with him. But these lists do have a few extra on them, as you can see. So hopefully that US list will become more robust over time. Like I mentioned, it came out in April of last year, and we know this has been a crazy year. So hopefully it's just taking them a little bit of time to prioritize that. So definitely take a look at those. I'll follow up with, his name is Dr. Ray Coates, and make sure that these two lists, the Canadian and UK lists, are still A-OK to use. But a lot of what I'm going to focus on today will kind of look at the US list, because we absolutely know that that has the validated list that we can for sure use. So with that, let's talk about those CPT codes. So like I mentioned, these came out in 2020. There are two of them. 99473 is the first one. And this is where we use SMBP with a device validated for clinical accuracy. Again, that would include those ones that we just looked at, the Omron, the A&D Medical, and the Hillrom Welch Allyn. Those are the three brands that are included in that US list. Now, this one can be submitted once per patient, and it's for staff time, and it will reimburse you for $11.19 for patient education through Medicare. So these two links right here will give you some ideas on what that education and training might look like. This is something, again, you can submit once per patient, so keep that in mind when we talk about the ROI. The next one is 99474, and this is SMBP using a device validated for clinical accuracy with separate self-measurements of 2 readings, 1 minute apart, twice daily over a 30-day period. Now that might seem different from that best practice we shared a couple presentations ago, but that 30-day period is more important for the actual submission of the CPT code and not as important for the actual clinical recommendation for measurement, which I'll get into in a little bit. The collection of that data is then reported by the patient and or caregiver to the physician or other qualified healthcare professional. And then you want to make sure that you have the average systolic and diastolic pressures and subsequent communication of a treatment plan to the patient also documented. So this one can be submitted once monthly per patient if those requirements are met. And this is some provider reimbursement at $15.16 monthly for data review and communicating treatment plan, again, through Medicare.
So this wouldn't be associated with an office visit claim. It would just be its own separate. How do we get it to the health plans, I guess, if there's not a visit?
That I guess that is my understanding. Let me look into that a little bit more. So I'm no coding expert, but I can definitely ask around and make sure I find out. So if this needs to be attached to a visit. Okay. I'll look through some of my notes and I will definitely get back to you on that. And I do want to mention before I forget, for the motivational interviewing question last week, I didn't see much on that, but I'm going to continue to look to see if there are any codes out there for that, but I didn't find anything in my initial search, but I'll keep up on that as well.
Yeah, because we're finding, yes, a patient can call in and give us our blood pressures, but if it's not attached to a visit, it just kind of sits in our chart and the readings don't go anywhere. So then we have them come in for a visit and that kind of defeats purpose a little bit. I don't know.
Yeah, so I can also ask some of my Missouri clinics that have been doing this for a little while on how they're doing the coding portion of this for the billing.
Thank you.
We have some that have been doing it for over a year now, so they should have a pretty good plan underway. So I'll ask some of them. So for this one, again, it does mention that device validated for clinical accuracy. And as I mentioned, the measurement protocol doesn't have to fit within that 30-day period. That's just how often you can submit this CPT code. The measurement protocol kind of still remains that 2 blood pressures 1 minute apart in the AM and PM for a total of 7 days with a minimum of 12 readings. Again, that's just so that you can make some kind of treatment plan based off of what you see the patient's blood pressures are at home. As we mentioned, the data collection and reporting do require documenting the average systolic and diastolic blood pressure, and the communication of a treatment plan to the patient must be documented. Unlike remote monitoring CPT codes, there is no digital or electronic requirement for SMBP data return. So those are the 2 codes. So I'm going to show you some return on investment for 2 of the devices that are on the US validated list. So the first one is for the Welch Allyn device. And this one is probably one of the more expensive ones that is on that list for the US validated devices. But there's a reason why I highlighted it, and that's because it has an extra large cuff. So in working with a lot of clinics, the biggest issue is that they have a lot of hypertensive patients that don't fit into many of the one size fit most cuffs that you might be able to get at the pharmacy. So the Welch Allyn, while it doesn't come with an extra large cuff, you can purchase one. I believe it goes up to about 22 inches, and some of the regular devices go up to 17, or some are only going up to 13 inches. So having those extra inches is definitely something that clinics that I've worked with have said is a major plus. So that's why I included it here. You can see that the Welch Allyn 1700, when we've spoken with a manufacturer, it's been $100.98. I believe that was through McKesson when we looked into all of this. And then that Welch Allyn extra large cuff came in at around $19.86. So kind of as a starting point, if you purchase 15 of those and 5 of the extra large cuffs, that would come out to $1,614. So then if you kind of got things rolling, if you have the CPT code reimbursement based on enrolling 15 new patients each month, you'd have that $99473 once per patient, which would equal $167.85. And then that once monthly per patient at $15.16. You would eventually, by month 7, you can recoup what you've spent on the devices, if everything is a perfect world and you're kind of able to start doing that right away.
That's relying on the patient to do it and give us the readings, right?
Yes, absolutely. Absolutely. We completely understand all of that as well. We know that there'll be some downtime in between getting the device back from the patient and all of that as well. This is just kind of a way to show whomever would be purchasing that you've kind of thought these things through. You know, you've thought about the fact that if we were to invest in some of this, here are some ways that we could do it. Might take a little bit longer than 5 months, but it's something that is sustainable as well. If you have a well-balanced loaner program which a lot of our clinics that we've worked with that do have these loaner programs, they haven't seemed to, outside of the fact that when COVID hit last March, they were kind of like, please don't give us your devices back because we don't know what this is. Outside of that, they really didn't lose many of these devices to patients not bringing them back. They had pretty good success with getting them back. So these are just a couple different scenarios with the Welch Allyn. Again, this is the most expensive one, I believe, from that list, but the benefit is that extra large cuff. The next kind of situation that's shown there is based on enrolling 15 patients and monitoring them for 7 total months. So if you just let them keep it for 7 months, you're not able to re-enroll new patients, but that's how long it would take you to recoup your cost. CPT code reimbursement based on enrolling 15 new patients every 3 months. Again, that shows you as well by month 8, because we're giving kind of that 1 month buffer for when you might have to wait for the patient to bring the device back to you, clean it, disinfect it, and then get it back into a new patient's hand. So again, this is just kind of, we know it's best case scenario, but if you are able to find some patients to start off with that are really reliable, that could benefit from this, maybe it would take an extra month or 2, but you could kind of show how you can make this program sustainable and recoup your costs on your initial investment. The next one is for the Omron devices. So this is the 5 series upper arm blood pressure monitor. These come in at around $55.99. They do not have an extra large cuff available. I believe that this one goes up to 17 inches, which is bigger than some other models that only go up to 13 inches, but it's still, I wouldn't consider it one size fits most. It's one size fits some. So there's CPT code reimbursement based on enrolling 15 new patients each month. Again, we have the $11.19 and the $15.16. So pretty quickly with these Omron devices, if you purchase 15 of them, you could recoup that cost. And then again, with the CPT code reimbursement based on enrolling 15 patients and monitoring them for 7 months, you can again, oh, I don't know why that says 7 months, but you can again recoup your costs at 4 months along. So that one definitely is about half the price or even less than half when you don't factor in the extra large cuff. So if you look at your patient population and feel that that smaller cuff size might be able to fit many of them, the Omron devices are a great alternative. The only downside being that they do not have that larger cuff size. So any other questions on those? And we can make those these pictures available to you in case you want to ever use them or look into them a little bit more. Or if you have questions about who you could reach out to purchase devices, we can kind of steer you in a couple different directions because I know plenty of different manufacturers have these. The next thing that's included in the CPT codes is performing a device accuracy test. So we really want to do these device accuracy tests because you can have some devices that do not match up to what's happening in the office. So Target BP, the American Heart Association, and AMA created this self-measured blood pressure device accuracy test worksheet. So with this, you would follow the steps here. So step 1, you utilize both the device. So let me grab one off the floor. When we initially started our other program, we bought Homedics devices. So a lot of our clinics have these. So unfortunately, they don't match up with the CPT codes. So that's why I'm showing this one today because I have access to it. But you would use the patient's device or this device for measurement A, B, and D. And then the office's, whether you use an automated or a manual blood pressure, you would do that as well and list the systolic blood pressures. You can see some example over on to the right. And then you would average the measurements B and D, compare the average of B and D to the measurement C. And if the difference is less than 5 millimeters of mercury, the device can be used for SMBP. If it's between 6 and 10 millimeters of mercury, you want to proceed to step 3. And then if it's greater than 10 millimeters of mercury, you want to replace the device before proceeding with your SMBP program. So A lot of devices also come with a warranty. So I know when we've purchased them, I think I actually today when I grabbed my first device, it wasn't turning on. So I'm going to reach out to the manufacturer. And typically what they did for us is that they'll just send us the new device and send us a shipping label. We'll pop that on there and send it back to the manufacturer, and no questions are really asked. So a lot of these devices do have a robust warranty system, so that pretty much anything is covered. So that's also very, very nice. So this is what you want to definitely use. Eventually, you'll kind of get the hang of what this process looks like. Kind of what our suggestion has always been is that if you ever have some downtime with your staff, that you could be validating your devices. So if you have 15 monitors in your loaner program, you could kind of do the device accuracy checks ahead of time, so that once you have the patient, you don't have to do the device accuracy test, and you can really just train them on how to use the device because you've already tested it compared to your office's machine. So if there's ever like a lunch and learn where you are talking about SMBP, knock some of them out right then and there. Go have your staff members go through this worksheet with one of your devices. That way you can kind of make sure that it's accurate. And if it's not accurate, I always suggest do this at least a couple of times before reaching out to the manufacturer. And if you find that it's still not accurate, then definitely reach out to the manufacturer to see if there is a warranty on it. Any questions on the device accuracy check? Okay. So last topic we're going to get into today is on infection prevention. So because of COVID, loaning devices kind of halted for a little while, but we really feel like there is probably a safe way to do it at this point, and we'll get into some strategies around that. So it's important to understand the difference between cleaning and disinfecting when protecting the longevity of our monitors while safely providing a clean and safe product to our patients. So cleaning is the removal of visible soil from objects and surfaces, and normally is accomplished manually or mechanically using water with detergents or enzymatic products. So on the flip side, disinfection describes a process that eliminates many or all pathogenic microorganisms, with the exception of bacterial spores like C. diff. So ideally, we want to do a coupling of these. We want to clean and disinfect. So we remove the surface pathogens and then disinfect to kill any residual pathogens. So the CDC does have guidelines for blood pressure device disinfection to prevent SARS-CoV-2 cross-contamination. So for hard, non-porous surfaces, which is what our devices are, you want to consult the manufacturer's instructions for cleaning and disinfection products to use. And then for electronics, again, follow the manufacturer's instructions, and then consider the use of wipeable covers for all electronics. I know, for example, when we reached out to Home Medics about their devices because we had them, they had recommended like a Lysol or a Clorox wipe for these. So estimates of SARS-CoV-2 surface viability. Sorry, my arrow kind of shifted down there. It's supposed to be pointing at plastic. So the estimated lifespan of SARS-CoV-2 on plastic is around 72 hours or 3 days. So we definitely want to keep that in mind. If you get a device back, those SARS-CoV-2 bacteria can live on the device for up to around 3 days. We also know that COVID-19 spread is not common with surface contact. Although it is not commonly spread through surface contact, touching the surface with the virus can be still a risk. So we definitely want to clean and disinfect the devices, wait the appropriate amount of time, and then safely provide the device. So if we couple cleaning and disinfecting with waiting that 72 hours, we can feel pretty confident that we're giving a safe device to patients. So our suggestion on how you could instill a process within your clinic. So this is kind of a bin system. We have a green bin, a yellow bin, and a red bin. The green bin is the clean bin. Ugh. Devices in that bin are ready for distribution. This will include new devices or devices that were disinfected with a minimum 96-hour hold. So we said 72 hours before, we're just giving it that extra day just to really make sure that the SARS-CoV-2 bacteria wouldn't be included, or virus wouldn't be on it anymore. The yellow bin is the observation bin, and this is when the device is on hold. So devices that were disinfected would go into the yellow bin and be held in that yellow bin for a minimum of 96 hours. And then finally, we have the red bin or the intake bin. And this is when devices are requiring disinfection. So once you get a device back from a patient, you would place it in there. Maybe if you didn't have enough time to clean it and disinfect it right at that point in time. You can place, we also want to recommend that we place the device in a protective bag for source control. That way, once it's in there, if a new device gets placed in, there aren't any cross-contamination. And then the person that's disinfecting is also responsible for cleaning and disinfecting the area where the monitors are processed. This is a log that could be used to kind of couple with that process. So you could place the device ID. We recommend kind of using a label maker to put a number on your devices so that you can keep track of them. You could put the patient's name, their last name, their phone number, the date and time that you loaned them the device initially, a staff initial, the due date of the device, and then when it was actually returned, and then a staff initial again of when you place the blood pressure cuff in the protective bag, and then the cleaning process. So the date and the time it was cleaned, the initials of the staff member that cleaned it, and the date and time cleared for redistribution after 72 plus hours post-return. Again, we recommend 96. And then finally, the initials of the staff member who finalized that cleaning process. So I'll make sure you have access to this log as well. I'll make sure I send that out to you. And then finally, this is the potential process. So a patient enrolls in SMBP. The care team member grabs the device from the green bin. The care team member fills out the device inventory management form, and the patient takes the device home for 2 weeks or whatever your clinical guidance is. The patient then returns the device to the office. Maybe your care team member is really busy, so they place the device in the red bin to be cleaned and disinfected later. Once that care team member has availability to clean and disinfect, they grab it, they clean and disinfect it per recommendations. The care team member places a device in a plastic bag and notes the date and time of entry on the bag. And then the care team member places the bag device within the yellow bin. The care team member then logs the information into that device inventory management tracker, and then 96 plus hours after the device was cleaned and disinfected, remove the device from the yellow bin and bag, and then place it in the green bin for redistribution. So this kind of walks a care team member through that whole process and what it looks like. Does anyone have any questions on that or any concerns that you can think of that might come up with this kind of process?
Just the patient returning the device, I would think would be an issue.
Yeah. So I know kind of the best practice with devices is that we never want to lose a patient because they didn't return a device. Obviously, we don't want to make a patient afraid of coming back into the office because they lost it or whatever else. So the best practice that we've always instructed is that you send 2 letters and make 1 phone call, or 2 phone calls and 1 letter to remind the patient about the device, but kind of in that letter, we have some resources that explain kind of wording that you could include to remind the patient that you don't want to lose them as a patient if they have lost the device or whatever else, that you still want to see them in your office so that they know that that's the most important part of this. But obviously it is a concern. Some strategies that you could use as well could be like, if you complete the SMBP program, here's a certificate of completion. So any sort of incentives for completing the program and bringing back the device are always great at kind of getting engagement in the program, first of all, but second of all, getting devices back. Some have done little goodie bags with ideas for recipes or Again, I know like YMCAs have programs, and some of them include a membership if you're enrolled in their their blood pressure self-management programs. So giving them tips and tricks around that type of stuff, and maybe like a small goodie bag at the end of an SMBP program. That doesn't have to be super costly, but it might just be like little things that can continue their road to health. So I think that's a great point, though. I know that was a concern with a lot of our clinics as well. But luckily they didn't lose too many. So it could be different patient populations, obviously, but it's definitely worth a try. Any other questions? Okay. So with that, I do have the list of references here. And now we will kind of chat about action planning. So this week's action planning looks at those device accuracy tests. So these are done in advance, or it's up to you, but they can be done in advance with staff and set aside, or they can be done at the point of care with the patient. So kind of the homework assignment for this week is to think about what would work best in your clinic and go from there. And it could be something that it depends. Like if you don't have one that's been tested for accuracy, you're going to have to do it at the point of care. But kind of making that a point to try to get your inventory set up so that they're ready to go can definitely help you with timing when you have patients in the office. Any questions on either of those? One thing I will mention is that you do want to do these device accuracy tests annually as well, so that you can make sure that the devices are still providing accurate results even after they've been used several times. In addition to that, if you are having patients bring in their own devices, you can utilize that worksheet for them as well, just to make sure that the device is accurate for what you're seeing in the office, so that when they go home, you know that it's not inaccurate. So definitely suggest using that worksheet for any patients that bring their own devices in as well. And with that, that is what I have for us today. Are there any questions about what we went over today?
Just to follow up from the last meeting, I did find out that our blood pressure costs that we have, the money came from a grant from one of the health plans that doesn't have a great system for providing these for their patients. So we bought a bunch of them. Now I'm looking at, they're not on the list for they're not one of the validated ones. So I don't.
Do you know what kind they are?
It's a Medline.
Medline.
I don't know if there's any more. I took a picture of the box because they're wrapped in plastic, and then the cuffs wrapped in plastic, the batteries. So they did not want me to
Oh yeah.
open one. Just says Medline automatic digital blood pressure unit.
Okay, well, let me look. Let me look if they're on either the Canadian list or the UK list as well. And then I'll reach out to Dr. Ray Coates and kind of ask him some of those questions. Obviously, it was definitely very confusing when they released the CPT codes and had this very specific thing about a device tested or clinically validated for accuracy when the US didn't even have that list available. And it's still very short, and now we're coming on to a year. I would think that if at that point in time, we had asked the question about, hey, if they're using this device accuracy check worksheet, can that also still count? And I would think that we want to get as many patients enrolled in SMBP and giving the reimbursement for CPT codes. It would be a good driver to get more clinics to enroll patients. So let me follow up with him and kind of explain the specific situation and kind of what we're hearing from a lot of clinics. That list is so short, and the best device on there that has the extra large cuff is the most expensive. So right. I definitely think that there have to be some good alternatives.
And to be honest, when we read the code, we didn't think that we had to refer to a list. We read it as using a device that we validated for clinical accuracy. So yeah, we thought we were good for using the codes.
And like I said, I think it's been a little wishy-washy, especially since those first 4 months of the year last year, that list didn't even exist. So those people who did not know, like if people wanted to get started on January 1st of last year and they bought 200 devices for their patient population, but they weren't on that list, were they just all of a sudden in April not able to utilize the codes anymore? So I think that's definitely a concern that's shared by a lot of people. So let me reach out to that contact. I haven't talked with him in several months.
Okay.
So maybe he has some updates on that. And there's been some discussion in the CPT code creator world that he could share with me. So I'll definitely reach out to him and ask him that.
Thanks so much.
Any other questions? I can ask, and that's when I'll ask him about attaching that to the visit too. Attaching the 99474 to a visit. Okay. Well, a little shorter this week. Next week, Jerry, do you remember what your presentation is on? It's slipping my mind right now.
Oh, you're mute.
Yep.
Muted.
Oh,
still muted, Jerry.
There we go. And I have to, you know what, I was gonna look, what I was saying is I was gonna look real quick to see what it is. I just have to pull it up. Getting started with your SMBP program is what we're talking about next week. So
thanks, Jerry. And then the following week, we'll look at just a bunch of resources. So if you think of any other topics, I know we had talked about reporting. I know there's some interest in some Minnesota reporting, but I'll also talk about other places where you might be able to report some of these SMBP findings, whether it be MIPS or whatever else. We can kind of chat about that a little bit. But if you have any other topics, feel free to let us know or reach out to us via email. That 6th session, I can kind of add any topics that you'd really like to dive a little bit deeper into.